Thank you very much for the invitation, and thank you very much for having me here for this milestone event of 10 years of minimal invasive parafascicular surgery. My name is Christos Soumpasis. I'm here to present our series from the past 2 years in King's College Hospital in London, in my department, in the setting of neuro-oncology. So let me take you through a journey from the concept that we came across 2 years ago, seeing the minimal invasive parafascicular surgery for the first time in London, to all the challenges that we are facing as neuro-oncology surgeons in our everyday practice, all the way to the integration of MIPS in our approach for our patients. And we will talk a little bit about the work that we're currently doing at King's College Hospital. So let's start from the concept, and the most important thing to note here is the transsulcal approach for the lesions. This is very important. As we all know, we had a lot of discussions yesterday as well in the workshop, because it's a white matter tract preservation method. We can preserve long association tracts, interlobal tracts in the hemispheric tracts. There's always the U fibers, of course, on the bottom of the sulci, and this is not always possible to preserve, but in general, MIPS is a white matter tract preservation method, and therefore we can preserve the function of our patients. And here we can see the summary of the concept of MIPS, as we saw as well yesterday. We start with a craniotomy, but of course, it's not the traditional definition of craniotomy. Here is the tumor, here is where we're opening. We have to consider all other aspects that you see on the slide, like our outer radial corridor, meaning the cortical function, the white matter tracts, so inner radial corridors, our target itself, what is the depth, what is the volume, what is the size of the lesion, but also what is the consistency. Is this a hard tumor? Is it a soft tumor? Should we go for a surface docking or for a deep docking of the lesion? And all this information that we can collect preoperatively will definitely be updated by the intraoperative information that we can get during the surgery, and this will guide the resection margins for our lesions, such as 5-ALA, intraoperative neuromonitoring, intraoperative ultrasound, etc. So let's look into challenging cases at King's College Hospital. I will start with one of the most difficult ones I find, multifocal tumors, and we chose to present a case of a young patient, 44 years old. As you can see, multifocal glioblastoma. This patient has clearly hydrocephalus with an enlarged ventricle. We had a discussion about this case in our MDT. Should we go for a traditional biopsy and a shunt? Putting a shunt in this kind of patients is always a challenge, because there is always a risk of spreading, of CSF spreading of the tumor cells because of the insertion of the shunt in the ventricles, or maybe occlusion of the shunt because of the hyperproteinic consistency of the CSF. We decided to go for the MIPS approach. We did our preoperative tractography. You can see the corticospinal tract on the back of the tumor. We decided to go for the intraparietal sulcus, and we performed elastogram as well to see the consistency of the lesion. As you can see, the lesion on the bottom, it looks harder than the tissue on the surface of the brain. So we decided to go for a surface docking in this case. Here you can see some images intraoperatively. You can see the projection of the lesion on top of the skin even before we start with the opening of the skin, and on the image down, you can see the projection of the MRI scan and the stealth navigation on our microscope view throughout the surgery. Those are just some examples of how augmented reality can help us navigate through the resection throughout the surgery. Here you can see the pre and the post-operative scan. It was a good resection. There is still a lot of tumor left behind. The reason why we stopped the resections because our recordings from the intraoperative neuromonitoring were very unstable. Nevertheless, we managed to achieve what we wanted. You can see that the ventricle size is smaller, that the septum pellucidum came back to its place. The patient did not need any shunt at all after the surgery. He was discharged 2 days later, and he had some chemo and radiotherapy in the weeks after. If we move to the deep-seated tumors, I have a case of metastasis, of a squamous cell metastasis. This is located quite deep. You can see it's quite sizable. There's a big cystic component. These kind of lesions are not amenable for SRS. So we always have to think of how we can help these kind of patients. And once again, we performed our preoperative tractography. We identified the optic radiation, the corticospinal tract. Once again, IPS was the corridor that we chose to approach the lesion. You can see how the brain is bulging at the opening of the craniotomy because of the cystic component, and you see the preparation of the sulcus, the insertion of the brain path, and the deflation of the cyst. And the last image is the view how it was at the end when we finished with our resection. We had to stop the resection at the bottom because we had positive corticospinal tract at 4 milliamps, so that we could see as well on the postoperative scan. You can see a small residual close to the corticospinal tract, but nevertheless, no restriction on diffusion imaging. The patient did very well, recovered from the hemiparesis, and was discharged 3 days after surgery. Intraventricular tumors, another challenging category for us. Here you can see a tumor that is not only intraventricular, it's also language and vision eloquent tumor. You can see again pending hydrocephalus, so we have to figure it out how we can help this patient. Again, preoperative tractography, we identified all the important tracts. You can see the acute fasciculus, the optic radiation, corticospinal tract. IPS was again the corridor of choice. You can see the tumor in the middle. And here some images intraoperatively. You can see the use of 5-ALA in these cases and how well you can identify the lesion, the tumor through the brain path. And the postoperative scan, again, good resection of the lesion without any damaging of the superficial brain tissue. This is a case that we published 2 years ago. It's another intraventricular tumor, this time on the anterior part of the ventricle. In these cases, we always choose the anterior corridor, so the superior frontal sulcus. This is an approach where you have to think about corticospinal tract, frontal astrand tract, FST, and how to preserve all these tracts. This was also another case where we saw the use of intraoperative ultrasound and how we can identify the ventricle with the ultrasound and navigate the insertion of the brain path, as well as, again, you see the 5-ALA, how clear it is for us to navigate for the resection margins. With this category will become a bit provocative. Brainstem tumors, are we there yet? Is this an option for MIPS? Our team think that not quite, but what we can do is tumors that are located on the posterior fossa, tumors that are very close to the brainstem, such as this metastasis here of this older guy, older lady, and you can see again the DTI. We identify the cerebello-dentato-thalamic tract. We had a very good resection of the lesion with MIPS via the posterior fossa, and again, no restriction of diffusion. The patient did very well and received whole brain radiation afterwards for the rest of the lesions. The most challenging for the last, functional eloquent tumors. This is the biggest headache for us, the neuro-oncology surgeons. This is where we start thinking about quality of life of our patients, how we can preserve their function, and how we can integrate MIPS with all the rest of the tools that we have available to us in the pre- and intraoperative setting. And this brings us to the integrated approach that we have for all these kind of patients. And let's start to see which kind of functions we're monitoring. As you see, motor function, visual function, language function. Someone might argue, I don't have the cognition there. And this is also something very hot topic for the oncology surgeons. We feel that cognition is not a function that is appropriate to monitor in MIPS setting because it's a minimal invasive setting. Cognition is a function that we control in bigger resections, in resections where we have an impact on the network of the whole brain in supramarginal resections, which is out of the scope of MIPS. Later, I'm going to talk a little bit about our protocols in rehabilitation. It's quite an exciting topic for us, but let's wait for a minute. Motor function. This is a paper that I like to call a historical paper from our department. It's back in 2017, where we noticed that 25% of our patients that are being presented to the neuro-oncology service and 40% of the patients that are being operated for any kind of glioma will have some sort of intraoperative neuromonitoring. These numbers are not accurate anymore. Nowadays, we're looking into numbers over 75, 80%. So it's pretty much a standard practice for us. And by motor function, we don't only mean the mapping of the brain surface and identification of the M1, as you can see in this case, but also monitoring of the motor function so that we can use this as a prognostication tool for our patients. For example, in this case that we published, we saw an improvement in the amplitude, increase in the amplitude and decrease in the latencies of the motor evoked potentials at the moment that we evacuated the clot from within the tumor. And we knew at that moment intraoperatively already that the patient is going to be profited by the surgery. And it did woke up with an improved deficit. Here you can see again another tumor that is very close to the corticospinal tract. You can see again the concept of the augmented reality. We are mapping through the brain path all the way down to the cavity. You can see the corticospinal tract as it is projected through the microscope, and good resection of the lesion without any damaging and without any residual. This is a view from our neurophysiology perspective. You can see on the top the bimanual technique, the probe suction on one hand and the myriad on the other hand. So we have resection, irrigation, and neuromonitoring at the same time. We had some positive MIPS on the bottom at around 8 milliamps, and this is where we are starting considering our resection margins. Usually we allow ourselves to go down to 5 or 4 milliamps. There's always this rule of thumb, 1 milliamp equals 1 millimeter away from the corticospinal tract, but this is only for up to 5 milliamps. When we go beyond that, the zone, this is a gray zone. We don't really know what's happening. This is another case that was quite didactic for us. We see that the better we understand the motor function and the anatomy of the brain, the better service we can offer to our patients. This is a TMS, a transcranial magnetic stimulation seeded tractography that we did for the motor area separately for hand and for the leg of this patient. We recreated the tract and we could see how the two areas for hand and foreleg are how they are related to each other and how they are related to the tumor itself and how the tumor is encroached within the corticospinal tract. This is another paper around 1.5 years now, where we're trying to create a concept of all-in-one instrument with a myriad. So we all know myriad is a resection instrument that fits perfectly for the brain path cases. What we can also do with a myriad is we can navigate simultaneously. And what we are also doing in my department is that we electrify the myriad via a crocodile electrode, and we can monitor throughout the surgery simultaneously with resection. So it's quite useful for us, and this is what we've been doing over the past couple of years. When we go to visual function, we like to separate our patients in two categories: the tumors that are laterally to the optic radiation and the tumors that are medially to the optic radiation. Here we have one of the first case. This is a lesion that is on the temporal lobe, very close to the Meyer's loop. We can see the tractography and the identification of the optic radiation, we decided to go for a MIPS approach via the superior temporal sulcus, and we could have a good resection of the lesion without any visual deficit for this patient. When it comes medially to the optic radiation, things become a bit more difficult. You can see on the image here on the sagittal where the tumor is. Someone can argue we could go for a suboccipital approach for the traditional craniotomy, or maybe even a supracerebellar transtensorial approach. Each one of those have their own morbidities. We decided to try again MIPS approach. We did our tractography. We identified a corridor that was below the optic radiation all the way down to the tumor. And this is exactly what we did in this case. Again, the intraparietal sulcus, you see the strip that is located towards the visual cortex, and we managed to do a good resection of the lesion. Throughout the surgery, we saw stable amplitudes of the visual evoked potentials, but we had a drop in the latencies, and we assume this is because of the mass effect while we were introducing the obturator in the brain. We know that this could be related to visual deficits postoperatively, but we have good chances of improvement of this, and this was exactly the case. The patient woke up hemianopic, but improved within a month's time. And this agrees with a recent paper that is actually currently under publication that we did on visual evoked potentials, where we see exactly that. The direct cortical recordings are much more accurate than the transcranial recordings, and the drop of the amplitude, even a 40% drop, is related statistically with a postoperative deficit. This is not the case for the latencies. This is another surgery where we would simultaneously monitor both motor evoked potentials and visual evoked potentials. You can see two strips entered in the cavity. One goes anteriorly towards the M1, and one goes downwards towards the intrahemispheric area for VEP recordings. You see the insertion of the brain path under copious irrigation. We would monitor MIPS and VEPs throughout this process. We had stable recordings, so we would reach the lesion. And soon we remove the obturator and we can proceed with the surgery when we reach this. Language function. How does language fit in the concept of MIPS? We feel that there are, again, two categories. We like categories. We feel that MIPS can be a solution for patients with tumors that are laterally to the association fibers for language, but they would not be appropriate for a traditional awake craniotomy, say elderly population or patients with established language deficits already, or patients with tumors that are medially to the association fibers, where again a traditional awake craniotomy would not be an option without significant deficits. In this case, we have an older patient, 73 years old, with a lesion that, as we saw in the tractography, was located exactly on the corner between the ventral and the dorsal streams for language. We decided to go for a MIPS approach again, and as you can see the images throughout the surgery, we used 5-ALA, again, good views of the lesion at the beginning of the resection. You can see that at the end of the resection, we still have some positive tissue on the bottom. This is where we identify the IFOF, and the patient would have repetitive semantic errors. So we decided to stop the resection over there. And on the image below, you can see also that we did fluoroscopy, and we could see good vascularization of the cortex at the end of the resection. This is the postoperative scan. The patient was discharged 2 days after the surgery with a stable language function and could have a short course of radiotherapy shortly after. This is a bit more complicated case. This is a tumor that is on the medial side of the association fibers, and this is where MIPS can be also very useful. As you can see on the MRI scan, where we did tractography as well, you can see the corticospinal tract, the arcuate fasciculus, the ILF, FAT, IFOF, all important tracts that we're looking into this area. We identified our corridor through the IPS one more time. And these are some images from intraoperatively. We kept the patient awake and we kept on doing object naming, action naming, the typical setting for language testing. You can see the 5-ALA vision as well, the neurophysiology setting. And this is the postoperative scan that shows a good resection with a little bit of residual very close to the tracts, as you can see that we acquired before the surgery. Our preliminary experience on awake craniotomy in the MIPS setting, you see we don't have big numbers at the moment, 6 patients, 5 of them were stable in terms of language function postoperatively. One of our patients actually deteriorated directly after the surgery. She woke up mute and hemiparetic because of the positive mapping of the negative network for language and motor, basically the frontostriatal tract. And this is a case of interest that I'm going to present now, and a case where we can see how the early rehabilitation can work as well. So let's dive into this case. It was an elderly woman, 78 years old, with a non-metastatic melanoma. She progressed despite SRS treatment, and she started having motor deficits. She was very keen to go for a surgery, so we did all the investigations, we did the tractography, and as you can see in this image, we were quite scared. The tumor is completely covered by all the important tracts, corticospinal tract, FST, frontoastral, and the IFOF on the bottom. This is one of those cases where we decided, okay, let's go for the MIPS approach, but we will have to sacrifice one of those. Corticospinal tract does not come into discussion, so we decided to go through the FST. We managed to do a very good resection of the lesion. We have done tractography after the resection as well, but the patient did wake up mute and hemiparetic, and this is where we started our early rehabilitation protocol in our hospital, which is based on a navigated repetitive TMS treatment. You can see here on the first day of the treatment, we are stimulating with low frequency on the contralateral SMA area in order to inhibit this area, and therefore we can try to provoke healing on the ipsilateral side where we had the resection of the lesion. You can see that already on day 3, patient improved much better. She can extend her arm by herself, which she couldn't do on the first day. And you can see on day 10, after the treatment, she's eating her pasta on her bed, and she's literally walking by herself outside of the hospital. That was a funny moment. She was complaining on that day about a bad hair day. So we knew that, okay, the main problems were dealt. We know, of course, in the literature that in SMA syndrome, you can have a recovery of the patients. 50% of the patients will recover within the first month, and another 20 to 30% will recover in the next months, in the following months. But our experience on the repetitive TMS treatment is that we can expedite this process, and usually patients can go back to their baseline within 7 to 10 days. This links also very well with the work in progress right now in King's, and she was not the only patient that underwent this protocol. We had 7 patients. I think we are at 10 right now that have undergone exactly the same protocol: preoperative tractography, MIPS approach for the lesion with intraoperative neuromonitoring, and early rehabilitation with repetitive TMS. 7 patients, all of these tumors were very close to the corticospinal tract, less than 1 millimeter. All these patients woke up with motor deficits. 3 out of 7 improved back to their preoperative functional status, and 4 of them actually improved even further to a performance status of 0. This is another paper in preparation, actually submitted now, where we can see pretty much historically how MIPS has evolved over the past 2 years at King's College Hospital. When we first came across with this concept, we used MIPS without any sort of mapping. Then later on, we introduced intraoperative mapping in the cases. And nowadays we have the whole concept with preoperative and intraoperative mapping with all the tools that we have. And as you can see, the more mapping we use, the better outcomes. Functional outcomes have significantly improved, and we can see also a much shorter length of stay for these patients. Another topic of interest for us in the MIPS approach is the ischemia that we might cause on the cortex, on the brain that remains after the surgery. And we looked into the 3 main corridors that we choose: the superior temporal sulcus, the superior frontal sulcus, and the interparietal sulcus. We see that there is significantly more restriction in diffusion via the temporal approaches. And we also compared the transsulcal and the transgyral approaches. And we can see again with our data that clearly transsulcal approach is related to less motor deficit and to a better motor improvement postoperatively. And not only ischemia, we're looking also at the vascular dynamics of the cortex. We are doing fluoroscopy intraoperatively with ICG before the resection and at the end of the resection. We are gathering data in regards to delay time, time to peak, rising time, and speed for the vessels. We have seen a pattern repeating for the patients that have already deficits after surgery, where we can see a decrease in the peak and rise time and an increase in the speed. We sort of explain this from a mechanical perspective. This is far from finished. We still have a lot of work to do. We just thought it's exciting to share with you. So what is MIPS for us? MIPS is clearly not a standalone technique. MIPS is a tool that we can utilize among all other tools that we can have in the setting of a neuro-oncology surgery, such as 5-ALA, intraoperative monitoring, ICG, endoscope, ultrasound. Not everything is on this slide, and it's definitely a technique that can help us deal with challenging cases. And this is also clear from our department. On these statistics that we did, we see that we implemented MIPS back in 2020, and we can see a clear decrease in the numbers of the biopsies that we are performing for glioblastomas. And this does not have to do with the fact that we're receiving less patients. In contrary, we receive more patients than before. But it is clear that we do not do just biopsies anymore. We are able to offer more to our patients. We are able to offer debulking surgeries and better outcomes. So to conclude, pushing the boundaries for resection, we can gain tissue for diagnosis, we can preserve the function of our patients, we can preserve the quality of the life of the oncology patients, which is of utmost importance, and we can deal with challenging cases where a debulking would not have been possible before this technique. We can avoid CSF diversion surgeries, and we can preserve the function of the patients. Here you can see the team at King's. We are all very proud of them. Prof. Askan is among the audience here today. We wouldn't be able to be here without all of them. And we are very happy to get any questions. Thank you.
Thanks, Dr. Soumpasis. A very eloquent study and work, and I appreciate that. You showed, which was of great interest to me, I believe the inhibition of the SMA with transcranial stimulation. Is what areas, what deficits do you target besides SMA for that?
So we use TMAs mainly for motor deficits. The SMA syndrome and generally all the association tracts like FST, FAT, corticospinal tract. We also are experimenting around language function with arcuate fasciculus. IFOF. We are still in the process of retrieving data. We definitely have very promising data at the moment. And especially when it comes to motor function, we see quite an improvement very quickly.
Okay. No data or experience yet with speech, though.
Very preliminary.
Okay, you don't want to say
The-
yet. Okay.
We're not there yet.
All right.
The case that I presented, she was
That's-
actually she recovered very well in terms of speech as well.
Yeah, very understandable. And I noted you start on post-op day one.
Correct.
Yeah, yeah, very impressive.
That's why also we just did the low frequency on the contralateral lobe, so we wouldn't go for high frequency on the ipsilateral side, so we don't induce any seizure activity.
Okay. Any questions, comments? Yes.
Yeah, great talk. I got sort of a broad question in terms of the size of the tumor for intraaxial tumors. Do you guys have any cutoff that you guys use?
We don't have clear cutoffs. The main question is, again, MIPS is more related to debulking and not really to supramarginal or gross total resection. So the size is not really the main issue for us. What we look into is the location, the patient himself, if they are amenable for any kind of treatment afterwards. So yeah, it's rather a combination of different factors.
Got it. And in terms of when you guys utilize intraoperative neuromonitoring, I kind of agree what you already mentioned. I think in terms of the subcortical stimulation, you guys use through MIPS, do you guys use in unipolar electrode? What's the workflow you guys typically use in the small corridor in terms of margins, if you're planning for supramarginal resection in those cases, and then you're using subcortical stimulation?
So we use direct cortical stimulation, as you see most of the times, with electrodes, with strip electrode on the surface to establish baselines as well. For the monitoring inside the resection cavity, we mainly use the suction probe, so monopolar electrification, but we also have used for the awake cases where we were trying to check on the IFO, for example. In that case, we used bipolar stimulation as well.
So you guys use the kind of the electrode with built-in suction? I'm just trying to.
Correct.
Is it the
So
one you use?
the suction probe is basically a suction that is electrified, and
Right,
you can use it as a monitoring tool. The other thing that we're doing is we electrify the Myriad as well. So we can use Myriad as a tool for neuromonitoring as well.
Great talk. Thanks.
Thank you.
Fascinating. Thank you again.
Thank you very much.